Okay, so we don't have any disclosures. Okay, so the objectives of today's didactic are to learn the signs and symptoms of alcohol withdrawal syndrome, to learn some ways to properly manage it, and to become familiar with the FDA-approved medications, and briefly touch upon the psychosocial interventions for the treatment of alcohol use disorder. So we're just going to start with a case that we'll kind of come back to show a few points here. Your patient, Ms. A, is a 41-year-old female who has a history of hypertension and opioid use disorder, presenting to clinic for routine follow-up on her blood pressure. She's been taking her buprenorphine and 2 blood pressure medications, and she's trying to follow a low-sodium diet and exercise routine. She quit smoking tobacco 2 years ago, but she does report daily alcohol use. And on physical exam, her blood pressure is a little bit up at 154/98, and the rest of her exam is normal. So you're concerned that her blood pressure could be uncontrolled and related to her alcohol use. So the questions are, how do we determine if she has a pattern of risky drinking or if she has an actual use disorder? So just to review our terms here, in the US, 0.6 fluid ounces or 14 grams of pure alcohol is a standard drink. This is going to be important in your assessment just to make sure if someone's talking to you about having a glass of wine at night, is that a 5-ounce glass or perhaps more, so that you know what the actual equivalent is in terms of drinks. And that will help define the pattern or risk associated with their use. So what is risky drinking? The National Institute on Alcohol Abuse and Alcoholism, NIAAA, defines it as follows. And these are low risk quantities for, when we talk about risk, this is for developing an alcohol use disorder. And these quantities that would be low risk apply, of course, only to adults who are not pregnant. So for women, that's no more than 3 drinks in one day and no more than 7 drinks in 1 week. And again, with metabolism differences, for men, that's no more than 4 drinks in 1 day and no more than 14 in 1 week. So if someone, for instance, if a man is having 2 drinks in 1 day, but they're drinking every day, and that would bring them up to the 14 drinks per week, then that's when that parameter then would qualify in terms of higher risk. So that's why both of those are important in terms of your assessment. Going to talk about SBIRT because this is a really important intervention that has been shown to have good evidence of effect in primary care settings. It was first developed in ER settings. And it has a grade B recommendation by USPSTF, meaning that it's covered by Medicaid and Medicare. And it's for screening for unhealthy alcohol use. So again, that's based upon those amounts. And this includes pregnant adults. And it's really meant to help to decrease the risk of negative consequences of use, but also to help identify people early, to help get them into whether it's treatment or another form of help to keep the risk from developing into a use disorder. It uses the 5 A's approach of ask about use, advise, assess, assist, and arrange, again, for the necessary follow-up. And sessions typically just last 5 to 20 minutes. So it's a very useful model that can be employed in primary care and other settings. So screening for risky drinking and alcohol use disorder, it's recommended to start with the single question approach about heavy drinking, which is how many times in the past year have you, for a man, had 5 or for a woman 4 more drinks in a day? And again, that's going on that established level of low risk versus high risk drinking. And if that answer is positive, then you would proceed to assess the severity. And this is exploring more if they have developed a use disorder using audit or the audit C that we'll look at in a minute, or other validated method. I included a couple more here. The MASS-G is more appropriate for a geriatric population, and the CRAFT for adolescents. This goes into the CRAFT a little bit more You would consider especially for younger youth, a lead-in perhaps about friends use, something to kind of um, um, introduce the topic, important to avoid ambiguity. So being quite clear and direct in terms of, for instance, during the past 12 months, did you drink any alcohol? So keeping it as clear as possible. And if there's any positive answer, then you would proceed with the CRAFT assessment. And CRAFT stands for, have you ever ridden in a car driven by someone using? Do you ever use alcohol or drugs to relax, fit in? Do you ever use alcohol or drugs alone? Then do you ever forget, or 2 Fs, or have your family or friends, counting I guess is the second F, told you to cut down? And have you gotten into trouble while using alcohol or drugs? So we'll return to our patient who is an adult. She responds yes to the first question regarding heavy alcohol use. And so you do administer the audit C and she scores a 7. We'll look at what that scale actually means in a second here. So upon further discussion, you learn that she's got significant fear of stopping use due to prior episode of withdrawal 2 years ago. And that withdrawal resolved when she resumed, when she returned to alcohol. And she also states that it is interfering with her home life and work and is asking for your help. So we'll go back to those elements of her story when we're determining if she has a use disorder. Just to show you the answers for her audit C, you can see here that she scored, the 3 questions are how often do you have a drink containing alcohol? And she had the 4 or more times a week, which brings her up to a 4 for that question. How many drinks containing alcohol do you have on a typical day when you're drinking? 3 or 4. And then how often do you have 6 or more drinks on one occasion, which is establishing more of a binge use pattern. So you can see here that with her score of 7, she scores positive. A score of over 2 identifies 84% of women who report hazardous drinking and over 4 for men. So talking about alcohol use disorder now, so different from risky drinking, how do we know if they need treatment? So first we have to establish a diagnosis. And if we look back at her, some of the elements of her history, we'll see if she qualifies for that. Meets criteria, I should say. So sometimes if you think of use disorder for alcohol and for other substances such as opioids in terms of 3 groupings, cravings, compulsions, and consequences of use. And then in addition, the 2 other criteria and the 11 total are tolerance and withdrawal. And anything over 2 does meet criteria for a use disorder, whether it's mild, moderate, or severe depends on the number of criteria. And so in her case, if we just go back briefly and look at her history, in addition to the amount, she is experiencing withdrawal in the past, and then it's interfering with home life and work, right? And so we have at least, we know 2 and most likely more criteria there. So what treatment can we offer her? So just to kind of broad strokes review what treatment looks like in the US is sadly pretty low. Only about 6% of adults and 5% of youth with alcohol use disorder diagnosed in the past year receive treatment. Less than 1 in 10 people in the US with a diagnosis of alcohol use disorder receive treatment of any kind. And most community programs, excluding the VA, only offer non-medication. So we want to try to develop strategies for patients to receive both therapy and offer of medication to help. And then also strikingly lower access for racial and ethnic minorities to mutual help groups, also especially by women. And so we definitely need to be focusing our treatment efforts. Some of the treatment options for alcohol use disorder we'll review here. It's basically, you can think of it in terms of 2 branches. So when you're seeing someone initially, we want to see, first of all, is there a need for acute management with medication, right? And then we want to talk about moving forward, what does relapse prevention look like to them? So just in their first instance, when they're coming in to see you, and this may differ in terms of if you're in an ER setting or primary care, what have you. But regardless, we need to determine if they need inpatient versus outpatient treatment. And inpatient treatment is namely if they are withdrawing and have a history. The main one would be a history of a prior seizure. That would be an indication for inpatient treatment. If we determine, however, that they're a candidate for outpatient and they are in active withdrawal, then the treatment standard would be to offer a brief, and by brief, it's usually no more than 5, sometimes 7 days, benzodiazepine taper. And that is really the mainstay for prevention of seizure. Other medications such as gabapentin or carbamazepine may be helpful in terms of other symptoms with withdrawal, alleviating those, but not first line for or not clear evidence for preventing seizure. And then the main thing that we'll focus on here too are what medications can we then provide moving forward, sometimes started at that same visit, sometimes a few days later, depending on their stability for relapse prevention. And we'll be talking about naltrexone, acamprosate, briefly disulfiram or antabuse, and then some off-label medication uses, gabapentin, baclofen, and topiramate. Sorry, this is a pretty small print, but it's just showing you our CWA scale. That is often used inpatient, but we also use it outpatient for initial assessment. So you're probably familiar with this, but just to briefly review, it's really a collection of subjective and objective findings for someone who is withdrawing from alcohol. And you can see here in the bottom right, the basic guide for when medication is needed for that acute treatment, namely when you're reaching the teens, and then definitely the higher teens above 20 want to consider hospitalization. So again, for managing that acute withdrawal, just to show you briefly the evidence here, 2010 Cochrane review of 64 randomized controlled trials showed that benzodiazepines are effective against seizure when compared to placebo. There's insufficient evidence for the use of anticonvulsants, but carbamazepine may be more effective in treating some aspects of alcohol withdrawal, and it has been also shown to possibly decrease the extent of drinking after the acute detox period. And there also, again, may be a role for gabapentin in mild withdrawal, but not for prevention of seizure. So returning to our patient, we administer that CWA scale, and she scores a 12, so kind of on the milder end, but moving into moderate. She does not have a history of a prior seizure. Head injury is another one that can put you at increased risk for that, and for hospitalization. She's not pregnant. She has support at home. So we review the options of inpatient versus outpatient, and she does opt for the outpatient detox, which in her case we deem appropriate. She returns after a successful taper at home last week, but she has strong urges to drink. So what medications can we offer? Another wordy slide for you. So naltrexone is really the medication that if someone is not also on medication for opioid use disorder or on opioids, that we would usually go to first. It has the largest body of evidence. It is an opioid antagonist. And so it works by blocking the effects of endogenous opioids that the body releases when someone drinks. And so kind of helps block that reward effect. And what it's really been shown to do is by decreasing that euphoria that experiences, it's been shown to decrease the chance that if someone's taking it as prescribed, if they have a drink, decreases the chance of an extended relapse. I'm sorry about the dings. I want to shut off my tiger, but I also don't want to get out of this screen and find it to shut it off. So I'm sorry. The FDA approved daily dose is 50 milligrams. And there's a long-acting form that's also indicated for patients who have opioid use disorder and aren't on other medication like buprenorphine. So long-acting naltrexone, the brand name Vivitrol, that's given monthly. Again, it's contraindicated in someone on opioids because if you were to give it to them, it would precipitate withdrawal because it would kick those opioids off and bind the mu receptor. It is recommended to have baseline and monitoring of liver function as it's processed by the liver. However, this isn't some contraindication. SAMHSA really helped change that guidance just in the last couple of years, where we wouldn't withhold this medication if we don't have baseline liver function. Clearly, if someone's coming in and they're showing signs of like decompensated liver failure, we want to use our clinical judgment there and wouldn't use this medication, but it's certainly something that we try to monitor, just like, you know, if someone's on a blood pressure medication, we want to monitor their renal function, but we're not going to withhold it from them if we don't have those just at the get-go. It can be started while someone is still drinking. So that's something that's important to clarify with patients, because sometimes, probably because of an association with the negative effects of disulfiram or antabuse, sometimes people think they can't take any medication if they're going to drink, that it'll make them sick. And it's important to clarify that it doesn't work that way, because it's actually when you're on the medication and you have a drink, like I said before, it should help decrease that from becoming too extensive. And again, good evidence, a Cochrane review of 50 RCTs, nearly 8,000 patients, showed that oral naltrexone decreased the relapse to heavy drinking to 83%. The placebo rests within a number needed to treat of 10, and decreased drinking days by 4% and heavy drinking days by 3%. So the combined study was a study you may have heard of that really showed the evidence of effect for this. It was the largest controlled pharmacotherapy trial in the States for treating alcohol use disorder. And basically what this trial looked at, just to be familiar with this evidence, was it randomly assigned patients to placebo and or acamprosate, which is the other FDA one we'll talk about, and or naltrexone, and all with medical counseling in the medical visit. But half of the patients were randomized to receive up to 20 CBI sessions. And what it found was that those with the naltrexone medical management alone and those with placebo with the CBI had the most substantial decrease in days drinking. So this was really where the evidence lay for having patients have this prescribed to them in the primary care setting with medical management. Okay, so just to shift gears here, we're going to talk about the second FDA-approved medicine, acamprosate. Works quite differently. By increasing GABA transmission, it's thought to stabilize the glutamate receptor. And so it's thought to help promote abstinence by alleviating some of the physical and psychological symptoms associated with withdrawal. Its daily dose is a little strange, and this is one thing that can make it kind of hard for some folks to take. It's 666 milligrams 3 times a day, and what that amounts to is 2 relatively large pills 3 times a day. For patients who find that middle of the day dosing challenging, having 3 pills twice a day is an option. Still a lot of pills, and it doesn't come in an extended release, so may not be for everybody. And it does have a fair amount of evidence that showed it decreased relapse to alcohol when compared to placebo, with a number needed to treat of 9. Importantly, it's not metabolized by the liver, but by the kidneys, and so that's where our monitoring, again, not to withhold treatment, but we would attempt to get renal function and monitor that. And it seems to be that its most important role is in preventing relapse in someone who's already off of alcohol. So again, it's not going to make someone sick if they start it or have a drink when they're on it, but the evidence lies mainly in having been off of alcohol for a couple of weeks. So we'll usually try to start it once they've been off of alcohol for a couple of weeks. And then just briefly to touch upon disulfiram, otherwise known as antabuse, because it really doesn't have good evidence of effect and causes this really horrible disulfiram ethanol reaction if someone comes into contact with any alcohol, which includes flushing, heart rate racing, palpitations, nausea, confusion. Not indicated if someone has significant liver disease or heart disease. And it's because of that effect, obviously, it's contraindicated if someone doesn't have a goal of complete abstinence. So it's really probably only reserved for certain few who feel that they absolutely need to take this. There are some patients who do say that they have to have this absolute type of medication for it to be effective for them, or maybe sometimes related to a job, maybe sometimes related to a family member, in which case they might be having it taken under supervision by somebody. But it's usually sort of reserved for just a select few who feel they need this type of medication. So not one we would offer at the get-go for sure. And then just to touch upon briefly, there are off-label medications for alcohol use disorder, as there are for many conditions. And these have been recommended by the APA for second-line treatment, in addition to or instead of if one of those FDA-approved medications hasn't been found to be effective. Topiramate has a largish body, 7 RCTs that showed more days abstinence and less frequency of binge drinking than placebo. But topiramate, you need to kind of increase gradually to help avoid some of the side effects. And some of those more significant side effects can be like the paresthesias, kidney stones. And importantly, women have to be on really good birth control because this has had teratogenic effects. And so have to be really, really cautious about that and give good, well-informed education so that patients understand that. Gabapentin has also some evidence that showed effect, but only on percentage of heavy drinking days. Target dose that was shown to be effective was 1,200 to 1,800 milligrams per day, which is sort of middle of the road, relatively high dose, but if patients can tolerate it, namely the sedation, to work up to that may be effective for them. And then you do need to exercise some caution, as gabapentin does have some potential for misuse. So again, the current APA guidelines are naltrexone and acamprosate are recommended first line for treatment of moderate to severe alcohol use disorder. I would say we do offer it if patients meet criteria for mild as well, and we do want to have medication in addition to behavioral health therapy services. And then they suggest the use of topiramate and gabapentin usually after trying naltrexone or acamprosate, and disulfiram again should not be used as first line. So with all of this information, how do we decide which medication to take? I think the main thing that we're hoping to get across with this presentation today, there's just a couple more slides here and we'll wrap it up, is that it hopefully is something that you feel is comfortable as maybe treating blood pressure in a primary care setting, being able to offer medication to help patients hopefully decrease their cravings and extent of use. We want to consider their coexisting medical comorbidities again, certainly if they have opioid use disorder and are on treatment for that with buprenorphine or methadone, for instance, then we would be offering acamprosate. So that's just one example of how we may shift which of these medications to use based on co-occurring conditions. We want to ask about their prior experiences with treatment. So usually what's worked before will work again. So if someone was on something and they stopped it for some reason, but it felt like it was effective at the time, it may be effective again. So go with that. Vice versa too. If it really didn't work for them, we may try something different. Want to ask them about their ability to take medication at a certain frequency. Again, that's geared more towards like that acamprosate sort of large amount of dosing, or if they might be interested in a monthly injection, that would gear us more towards the extended release naltrexone. And then we definitely want to consider psychiatric comorbidities and want to be sure we're offering treatment for co-occurring mood and substance use disorders, because oftentimes one, will feed the other. And so if someone's presenting with co-occurring anxiety, depression, for instance, and alcohol use disorder, we want to be offering treatment for both. One trial of 170 patients showed a significantly higher rate of abstinence with naltrexone and sertraline than with either alone in patients who had those co-occurring conditions. And to my chagrin, this shouldn't be just a one slide, but Dr. Plum's the expert in this, but I definitely want to mention how important the behavioral interventions are for alcohol use disorder. So just to briefly, not doing it justice, but briefly review the brief intervention again. These were shown to be very effective. So a meta-analysis of 34 studies and N of over 15,000 participants showed that those receiving a brief intervention took in less 1.5 standard drinks, again, going back to that quantity that we introduced in the beginning, than those in the no intervention group after 1 year. Did not show much effect on the frequency of drinking or binge drinking days. And this brief intervention, again, includes feedback, responsibility, advice, providing a menu of options to the patient, and expressing empathy and acknowledging self-efficacy. Typically, this leads to a 20 to 30% reduction in heavy drinking, and significant effect has been found in some studies for up to 2 years. Certainly, remembering our motivational interviewing skills, and multiple studies showing the benefit of MI in treatment of AUD. It's been shown to be most effective early on in the first 3 months with younger populations who have an occasionally heavy drinking but low clinical dependence on alcohol. So that's, again, kind of looking at that SBIRT model too, that you want to really try to make sure that we're continuously screening, especially in younger populations as well, not forgetting the youth and how many people do start in their teenage years, to see if we can try to keep that from developing into a more severe disease, or any at all if they're not clinically dependent. And then our mutual help and AA groups, this has been shown to increase days off alcohol at both 3 and 15-month follow-up. Again, a review of 8 trials didn't show evidence of efficacy standalone intervention, but certainly in combination with other therapy. And I'll just say with, especially with AA, but with mutual help groups in general, if certainly some patients may not feel that it's for them, and kind of exploring other options that may be out there, which may, range, especially for younger populations online, other groups that may be helpful, that may not make them feel like they have to follow any particular model. In the past, something may not have worked, something different may work in the future. So same with medication, kind of exploring that with them to see what might be most beneficial. And then family involvement has been shown to reduce drinking in 5 trials. So there's a plug for that one. It is helpful for patients. Certainly isn't always, depending on the relationships and dynamics there, but when it is helpful and supportive, involving family can be key. So to close our case, after obtaining our baseline kidney function tests, we decide to start a Camprosite. We're starting it at 1 pill 3 times a day, but just increase it to the target dose by the following week of 2 pills 3 times a day. And again, the reason we chose this one in this patient is she was also on buprenorphine, so we couldn't provide her with the naltrexone, which is the antagonist. And we encourage her to keep taking her medication. She agrees to meet with our clinical psychologist for CBT. And at her 1-month follow-up, she's reporting that she had a lapse last week with 1 glass of wine, 1 glass 5-ounce wine, but this did not lead to a relapse, and she hasn't had alcohol since. Her blood pressure is also normalized. She did screen positive on the PHQ that you administered for depression, so you decided to add sertraline to her regimen. And she's reporting an improvement in her mood and length of time off alcohol. So in summary, we want to screen youth and adults for alcohol use disorder on a routine basis using our validated tools, be able to diagnose risky drinking versus alcohol use disorder, and treat AUD promptly. It is the most undertreated health condition in the US, however, accounts for significant morbidity, one of the most, but I think it was like 30th on the list of chronic health conditions. However, accounts for significant morbidity and mortality. And we want to be able to assess withdrawal risk, recognize the need for inpatient versus outpatient management, and counsel patients regarding different treatment modalities for alcohol use disorder, prescribe indicated medication, refer to treatment, and other support.